Hello, my name is Terry Rudd. I'm going to be doing Hemodynamics Part 2, and on this section I'm going to talk a little bit about hypertension, and I'm going to talk about how hemodynamics are affected with every dysrhythmia. So basically, just as a quick review, deoxygenated blood enters the right side of the heart via superior inferior vena cava in a third area called the coronary sinus. From there it goes right atria through the tricuspid valve to the right ventricle to the pulmonic valve. Pulmonic valve, you have your pulmonary arteries with 5 main branches. The pulmonary arteries branch to many pulmonary arterioles, and they go to millions of capillaries in this alveolar capillary area. You get an exchange of gases. You exhale CO2, water, and 16 to 17% oxygen. You inhale 21% room air oxygen, which then goes to the pulmonary vein, to the left atrium, through the mitral valve, to the left ventricle, to the aortic valve, and to the aorta. And from there, the blood is pumped up to the nose and down to the toes from the left ventricle. Now, earlier I talked about the fact that if we had a normal blood pressure, say 110/70, this left ventricle pumps against that resistance. The forward resistance is called afterload, or we would call it the systemic vascular resistance, but it's easily reflected as the blood pressure. In that afterload, the fluid also has to go forward. On the right side of the heart, the pulmonary artery pressure is 25/10, and what the right ventricle has to pump to is the pulmonary artery pressure, which is 25/10. That's the afterload of the right side, called pulmonary vascular resistance. Now, both the left and the right side have something called preload, and the preload is the fluid before contraction. The preload on the right side, which I failed to mention in my part 1, is the CVP. I may be redoing the part 1. The preload on the left side is reflected by what we call the pulmonary capillary wedge pressure, or the pulmonary artery occlusive pressure. You'll sometimes see it that way, but you need lines for that. You need a Swan-Ganz catheter. Now, when somebody has hypertension, if they have a blood pressure of, say, 210/120, what ends up happening is this left ventricle has a job and a half because it has to pump to that pressure. Initially, the left ventricle is going to be fine, but over years it's going to end up failing. The reason I like to talk about hypertension is about 95% of hypertension is idiopathic. We do not know the cause. As a result of that, hypertension is generally not a blame game. Hypertension is generally a problem of having sucky genetics. And treating it is a little bit of a trial and error, trying to figure out which drugs work. The reason I'm such a proponent of treating the hypertension is hypertension untreated will lead to congestive heart failure. And then you have a muscle that can't pump well, and the person feels terrible the rest of their life. So the idea is to really partner with a physician to get onto the right drugs, and it's sometimes going to take 2 or 3, combination thereof. Now, getting back to hypertension, if this left ventricle has to pump to that pressure, it's eventually going to fail, and the fluid, instead of going forward, backs up, and that's why it leads to CHF. The left side almost always fails first, followed by the right. Now, hypertension can be treated with diuretics, which gets rid of the preload. It can be treated with vasodilators, which opens up the afterload. Okay? And the vasodilators, especially the nitrates, also will decrease preload because they cause dilation in the body system so that less fluid returns to the heart. Other treatments for hypertension are those wonderful ACE inhibitors and ARBs. The ACE inhibitors are angiotensin converting enzyme inhibitors. In the kidneys, we have a substance called renin, which goes to angiotensin 1 in the liver, angiotensin 2 in the lungs, that causes vasoconstriction. The ACE inhibitors prevent the angiotensin 1 from going to 2 in the lungs. And by the way, a common side effect of those drugs is a cough. The ARBs, which are the angiotensin-renin blockers, prevent the renin from going to angiotensin 1. Keeping in mind that most hypertension is idiopathic, we don't know the cause. In this next segment, I'm going to talk about how cardiac output is affected by the various dysrhythmias. Cardiac output equals heart rate times stroke volume. Now, the heart fills in two phases. We have passive filling with blood returning from the atria to the ventricles, and then when the atria contract, they add 20 to 30% more blood, called atrial kick. Atrial kick. The secondary filling of atrial contraction is called atrial kick. It adds 20 to 30% more preload. So the problem is any rhythm that doesn't have a P wave doesn't have atrial kick, and therefore affects up to 20 to 30% of the cardiac output, because it affects 20 to 30% of the stroke volume. So this includes rhythms with no P. We then have rhythms that are called brady's. And bradycardias are any rhythms that are below 50 or 60. Heart Association defines below 50, but we can accept below 60. And I think you can see that on the heart rate times stroke volume, if we have a bradycardia, we have decrease in heart rate. And if we don't have fantastic stroke volume, it's not going to happen. Now conversely, Lance Armstrong, being an athlete, has fantastic stroke volume, and his resting heart rate is 34, and he's okay, because his stroke volume is so good. Now the other rhythms are the tachycardias, which is any heart rate above 100, and of course we're interested in the heart rates also above 150. All of these are supraventricular tachs. When we talk generally above the narrow complex, a wide complex tach is called a ventricular tach. So V tach is wide complex, supraventricular tach is narrow complex, okay? Now, tachycardia has a twofold hemodynamic consequence. One hemodynamic consequence with tachycardias is as we're getting the filling of the ventricle, and you may remember Starling's law of the heart, where the intercalated discs stretch, the ventricular muscle fibers stretch, and the more stretch it has, the better contraction. The secondary hemodynamic consequence that occurs with tachycardias is this is the outside of the heart muscle. We have two coronary arteries. We have the left, which branches to the left anterior descending and circumflex, and we have the right. Both these coronary arteries arise from structures that sit right on top of the aortic valve. What ends up happening with a nice heart rate of 70? You get ventricular systole, and the coronary arteries get a nice filling of blood and oxygen. Nice filling of blood and oxygen. When you have a tachycardia, you get little fill, little fill. Because of where these coronary arteries are structurally located, they have to fill on diastole. They cannot fill on systole. There's too much force. They fill on the backflow. So anytime we have a tachycardia, we have a twofold hemodynamic consequence. We have decreased stroke volume because there's not enough time to fill the ventricle and stretch. We also have decreased filling of the coronary arteries, which can cause myocardial ischemia, irritability, and premature beats. And then the last thing we have left are the pulseless rhythms, which fortunately, the more life-threatening rhythms are the easiest to pick up. Like there's this one called asystole, and of course there's no cardiac output. You don't have anything. You have ventricular fibrillation, which is a quivering ventricle, no cardiac output. And then you can have your ventricular tachycardia with or without a pulse. If it's without a pulse, of course, no cardiac output. And the last one we have is something called PEA, which is a normal-looking rhythm, but it's electrical activity only, and therefore no pulse. So, of course, all the pulseless rhythms have no cardiac output and need compressions. Thank you very much, and I hope that helps you understand it a little better.